The TAILORx trial was developed as a prospective trial to look at the genomic assay, the recurrence score, and how well it would do in predicting chemotherapy benefit. Up to the time of the TAILORx data, we were utilizing retrospective prospective studies, for example, from the NSA-BP, B14, and B20 data sets. Now, this was very good data that showed that the recurrence score gave us excellent information for patients with a recurrence score less than 18, for example, or greater than 30. But there was a question about this intermediate group. Was there actually a benefit or not? And because there was a question for the intermediate group, there was also some questions about the recurrence score around the 16, 17, 18 numbers, and also the 26, 27, 28 numbers. So the developers came up with this idea that we would take women that were estrogen receptor positive, lymph node negative, and HER2 negative, and we would have them get the oncotype score. And then for patients that had a recurrence score less than 11, they'd go straight to hormone therapy. But for patients that had a score between 11 and 25, they would get randomized to either hormone therapy alone or hormone therapy plus chemotherapy. And this trial was really going to show in a prospective fashion, do women actually benefit from the addition of chemotherapy with a recurrence score between 11 and 25? Now, the higher recurrence scores went straight to chemotherapy, so it was specifically for patients between 11 and 25. And the TAILORx data took a long time for it to be available because, gratefully, all of these women did very, very well. And what it showed is that in those ranges between 11 and 25, there was no benefit with the addition of chemotherapy to these patients. Now that we have the data from the TAILORx study, it's really important for patients to understand that the majority of women that have estrogen receptor positive breast cancers that are node negative will not benefit from the addition of chemotherapy. It's extremely important to realize that we can save women from getting these unnecessary treatments that have a significant number of side effects. So it's extremely meaningful for women that have lymph node negative, ER positive breast cancers in this day and age. When we see a patient in our clinic that is estrogen receptor positive and clinically node negative and is HER2 negative, we utilize the genomic assay to get a better idea of what the biology is of that breast cancer. But we also look at some other factors of that patient's clinical picture to help decide on what the adjuvant therapy should be. For example, if a patient has a low recurrence score, for example, less than 25, she likely would be offered endocrine therapy. But then the question is, should she get tamoxifen? Should she get an aromatase inhibitor? How old is that patient? That makes an important decision factor for what type of adjuvant therapy. And even for young women, you might even consider ovarian ablation or ovarian suppression based on this recurrence score and the patient age. So the recurrence score really does help to identify the prediction of chemotherapy benefit, but it can also give you information about how to change or augment your endocrine therapy with the different aspects of what is available for those patients. The TAILORx data was specifically for women that had a recurrence score between 11 and 25, because these were the women that were randomized to get chemotherapy or not. But this was for all women, regardless of age, tumor size, or grade. There were some exploratory analyses that looked at different cohorts of women, for example, that have different clinical risk, so low clinical risk based on tumor size, grade, and patient age, for example, and high clinical risk based on those same parameters. It also looked at specifically age and menopausal status of patients and small cohorts of recurrence scores as well. So these exploratory analyses were used to see, were there any groups of women with these recurrence scores that would potentially benefit from the addition of chemotherapy? All of these exploratory analyses, whether you group them by clinical risk score or menopausal status or smaller recurrence score groups, none of these analyses showed that women would benefit from the addition of chemotherapy in those cohorts. So it wasn't helpful in predicting chemotherapy benefit. However, there was some significant information with regards to prognosis for those patients. So based on these genomic assays and the recurrence score numbers, adding these clinical risk characteristics definitely gives more information with regards to prognosis. So you really can understand, for example, a woman that has a lower recurrence score and she's not going to benefit from chemotherapy, but she does have potentially a higher risk of recurrence based on these other clinical characteristics. And what that helps is it helps for the oncologist to understand, is there another endocrine therapy that I could offer this patient because she has a higher risk? Are there any clinical trials that this woman would benefit from if she could undergo these based on her clinical risk scores as well? So these exploratory analyses really did help identify prognosis characteristics, but didn't show that there was any predictive capability when added to the genomic assay.